Mr. Chairman, for that update on the activities of the RSM cover. Bernard, unfortunately, is unable to attend the meeting, so today I'll be presenting on her behalf. So my name is Eddy. I'm the Robotic Fellow at Kenton Canterbury Hospital, and today we'll be presenting the paper Lessons Learned from 1010 Robotic Assisted Prostatectomies. So I'll give you some background first on our program. In East Kent, we established the robotics program in 2011. And to date, we've done over 2,000 cases, approximately 260 prostatectomies per year. And in the GIRF 2015 data, we were the highest volume per surgeon at 133 cases. And this has enabled us to accumulate the 1010 over the course of about 8 years. Our data acquisition has essentially been fully prospective, and we've managed to accumulate a complete data set by gathering it at the point of care. We've used only validated tools for our functional outcomes and used a bespoke database created by Mr. Eddy on FileMaker Pro, which enables us also to do a bulk upload of data to the BAUS audit and provide live results to patients at the point of contact. Here you can see our demographics for the series. The average age, 63.8. Essentially, these demographics are consistent with other large volume series that have been reported. The main thing to point out here is that our TERP rate is about 6.8% of patients. So those are 6.8 who had TERP prior to the route. And if we look here at the preoperative histology, the most interesting finding here is actually that ISOPS 1 or Gleason 6 represents only 3.2% of the series. This is extremely low in comparison to other large volume series. And essentially, I think this can be attributed to the fact that we've got a very active surveillance program, and many patients are enrolled in that. There is, of course, the possibility that they may be upgraded, and if that happens, they'll be offered active treatment in the form of radical prostatectomy or radiotherapy, so that's 8.5% of the sample that were recorded. Looking now at our operative results, you can see the average consult time is 119 minutes across the full series, and that included 40% training cases. The mean blood loss is about 233 mils, and there were no intraoperative transfusions, though you may see there were a couple of patients who were unable to perform the procedure on because of failed access, and 2 patients had a bowel injury recognised and repaired at the time without sequelae. I'd like to hone in on the consult times, and if you look at these, you'll see that the average time for the first 100 cases versus the last 100 cases has dropped by about 40 minutes. In fact, the chart shows that the drop in time is fairly steady and plateaus at around the 700 odd case mark. This is really valuable information in terms of planning longer lists such as 3 or 4 prostatectomies in a day, because you need to consider resource allocation. I'll move on now to our post-operative results, and we've managed to achieve a very steady discharge day 1 rate of 94%. You may assume that the readmission rate would be higher because of this, but actually it's 3.2%, it's quite low, and we've had no deaths. I think this is attributable to the excellent teamwork that's provided through the hospital, and the whole department is geared towards getting these patients sorted out and home quickly and safely. So our major complication rates, essentially there are 5 patients who have had significant bleeding events that have required interventions, whether that be return to theatre or embolisation. The remainder of the complications are more obscure or unusual things that have resulted in a total major complication rate of about 1% through the series, so 10 patients total. That being said, lymphadenectomies have a higher complication rate, particularly the extended nodes. As you can see there, it's about 10% of the sample, roughly split evenly between lymph leaks, lymphedema, and lymphocele. We changed our practice early into the series and had started out doing obturator nodes only, changed to an extended node dissection, and with that has come this complication rate. Relatively important because when we consent the patients, it is critical to explain to them these are not insignificant problems. I'll just draw your attention now to our histopathology results. And what you can see here is that of the 1,000 cases, 44.9% were actually T3 disease. This is higher than most other series, and the likely explanation for that is that without doing Gleason 6 prostatectomies, we're taking on probably a bit tougher disease or likely more aggressive disease, and that carries with it a higher T3 rate. That being said, the margin rates have been very steady, and you can see there that the margins are in fact pretty consistent with international series. Looking at the chart next to it, the interesting finding is really that despite having done now 1,000 cases, the margin rate, although a little bit fluctuant, never really decreased significantly. That may be attributable to the fact that there was some fellowship training prior to the surgery, the collection of the data, or that the cases have changed over time. I'll just draw your attention now to the functional outcomes, and here you can see the urinary continence data. Interestingly, our preoperative questioning found that 24% of our patients had a degree of incontinence before undergoing surgery. That being said, we've achieved social continence at 12 months in 88% of patients, or 92% at 24 months, and if we accept the definition of continence being 1 pad or less, we can get up to 98%. Having said that, there have been some patients referred on to tertiary centres to intervene for their incontinence, representing about 4.5% of the patients, of which 3.2% had an intervention. I think this is relatively important again because we need to recognise that if you have some incontinence prior to the surgery, it's likely that you'll have a longer period of recovery of your normal continence. So the erectile function, the last point that I'd like to really make here, our preoperative data was very thorough. We got 95% of the patients returned the survey at the time of the care. And the preoperative data showed that 54% of those people had a degree of impotence to begin with, and actually 30% of them had a significant degree of erectile dysfunction. So how do we classify good erectile function? And standard definition would be that the patient can have penetrative intercourse after the surgery. But I think in our circumstance, we've looked at it a bit differently, mainly because when we consider these patients, some of them will be able to get erections but are not interested in sexual activity. They're hard to classify. When we consider the patients who've had an erectile function sufficient for intercourse, in those patients who've had a bilateral nerve spare with a preoperative shim greater than 20, that is, who had good erectile function before the surgery, this represents 25% of our sample, 86% were able to achieve satisfactory erections sufficient for intercourse. Having said that, if we take the definition to be people who can return to their shim score that they had prior to the surgery, it's more like 60%. So these tools are a bit imperfect, but considering the actual function, you can see they're 86%. So what are the lessons that we've learned? Well, I'll just summarise basically. If we were to crystallise it down to one point, the main thing to say would be that as a team, we can achieve these results together. It's not just one surgeon, it's the people who've trained around him and the team that he's developed around him as well. These are the crystallised messages. Thank you for listening.